Thank you for the introduction, and let me thank Carlo and the scientific committee for having invited me. I'm so sorry for not being with you today for this Congress. This is the first time that I miss the LH Congress in person, and but again, as you said, it was really impossible for me to get to you. Okay, so I'm going to share my screen, and please help me in saying that everything is okay from your side. Okay, so can you see my slides now? Okay. So again, thank you for the invitation. Very quickly through my disclosures. Uh, I will start from here. Okay, so well, you know very well what I'm going to talk about: ovarian folliculogenesis, which is considered by everybody as a complex process divided into two different phases. Well, the first phase, which is considered gonadotrophin independent, and the last part of ovarian folliculogenesis, which is considered to be gonadotrophin dependent. However, if you go through literature, you will find some articles by well, many independent groups that over the years have reported that granulosa cells from very early follicles, well, they may show some degree of expression of FSH and LH receptors. And of course, expectedly, the intensity, the degree of the expression is increasing with increasing follicle diameter. Uh, Also, we have some studies in which ovarian follicles from animals, from mice, have been cultured with or without gonadotrophins. You see here very small ovarian follicles which have been cultured, and well, when the FSH was added to the culture, well, a good proportion of follicles could reach the antral stage, but this proportion, the proportion of growing follicles, would increase if you add LH other than FSH to this system. And well, you see here when the optimal concentration of both the two gonadotrophins is used, then 85% of small follicles could reach the antral stage. Well known, I mean, ovarian follicles, they need LH because LH is promoting many things, but in particular, when talking about steroidogenesis, well, LH is promoting synthesis of androgens, and in the end, androgens are the main substrate for aromatase activity, and estradiol is fundamental in ovarian folliculogenesis biology, because estradiol is inducing a further increase into the expression of FSH and the LH, which is the basis for the recruitment and for the growing and ovulation of ovarian follicles. So now, with all this information in our brain, let's move to the in vivo side of the story. You have here two women, Anne and Betty. Both they are 25 years old, we can say, but they have a very different functional ovarian reserve. Functional ovarian reserve is how we call the pool of recruitable antral follicles. So despite these two women, they have the same age, well, they have a very different functional ovarian reserve when expressed according to the antral follicle count and the AMH. Now, we may think that, well, these two women may have a different functional ovarian reserve because in the end, they have a different true ovarian reserve, namely the number of primordial follicles, which is the true ovarian reserve, may be different and may be low in Anne and high for Betty. Of course, this is one possibility. But the other possibility is that in reality, these two women may have the same number of primordial follicles. What is changing is the rate of progression of follicles from the primordial stage to the antral stage, because we know that the rate of progression may be different in different women. And if this hypothesis could be true, then let's see whether uh, we have some clinical condition which can be used as a model to investigate further this possibility. Hypo hypogonadotropic hypogonadism, hypothalamic amenorrhea. This is a condition associated to very low concentration of LH and FSH. And if we go through the few articles dealing with the AMH concentrations in this particular group of patients, then we conclude that probably the mean AMH levels are not so different mm, with respect to what we found in normal cycling women. But in reality, if we go in depth into these articles, we can find that, well, relevant quote of patients may have very low AMH concentrations despite they are very young women. And this has been reported by many authors. Again, you see here mean AMH values. In the end, they are quite good, but there's there's a relevant percentage of women with very low AMH concentrations. Again, Sontag and again other authors could find in the end that a relevant quote of women may have very low AMH concentration. The idea here is that probably those women with a long-lasting hypo condition in the end may turn up with a very low AMH concentration. And another particular condition associated to hypogonadism is pregnancy. Have you ever measured LH and FSH during pregnancy? Yes, we did it, and we found very low concentrations of LH and FSH. In particular, during the third trimester, LH may be almost undetectable, and this is because of very high concentrations of estradiol and progesterone produced by the placenta. And what about the AMH? The AMH decreases as well throughout the pregnancy by 50%. There's a 50% decrease in AMH concentrations. Why AMH is decreasing? Probably because of the very low concentrations of gonadotrophins, which in the end may change the rate of progression of ovarian follicles throughout folliculogenesis. Pill. Hormonal contraception is in some way inducing low concentrations of endogenous LH and FSH. And as a consequence, many authors have reported reduced concentrations of AMH, minus 31% for the AMH, minus 29% for the antral follicle count, and the ovarian volume is decreased as well. And I very much like this article, this study, because this is a prospective study, including 64 women under the pill. The pill has been stopped, has been discontinued, and expectedly, LH and FSH, they came back to basal levels in just 1 week. And what about the AMH? AMH went up by 53%, and 41% was the increase in the antral follicle count 2 months after pill discontinuation. Very, very interesting. On the other side, we have young women, young girls with a hypergonadotropic condition, so precocious puberty. And you have here a group of 15 girls with a precocious puberty, with well, they had high FSH and LH concentrations. They were treated with the degenerate agonist, and during the degenerate agonist treatment, FSH and LH became undetectable. Then the therapy was discontinued, and expectedly FSH and LH went back to basal values. What about the MH? The MH was high at the beginning, was low during the degenerate agonist triggering, and again went back to high levels after 3 months after the discontinuation. And again, the decrease of the AMH during GnRH agonist treatment was 50%. So in the end, it seems that we can modify the pool of antral recruitable follicles by acting onto gonadotrophin concentrations. And now let's move to the IVF side of the story. So again, we have here a woman with hypothalamic amenorrhea. She's very young, 28 years. And because of the hypothalamic amenorrhea, probably the low antral follicle, the antral follicle count and the AMH were very low. And so all of you know that if we go for IVF, if we go for the maximal ovarian stimulation, well, in any case, this will lead to a low number of growing follicles, a low number of retrieved oocytes. So this woman will be categorized as poor ovarian responder. But is this ovarian reserve poor because of a poor number of primordial follicles or because of poor number of antral follicles? So because of this, we proposed a couple of years ago what we called the extended LH administration, the extended LH ovarian stimulation, which is a new way of thinking about ovarian stimulation. Now, we are talking now about the prolonged ovarian stimulation in order to possibly modify the pool of antral follicles. And I'm going to show you a couple of cases today. We have here a 24 years old woman. She was thin, secondary amenorrhea, very low gonadotrophin concentrations. So she had hypothalamic amenorrhea, and she was addressed to IVF because of male factor of infertility. She was treated maximally 450 units of gonadotrophins, FSH plus LH, GnRH antagonist control, just 3 mature oocytes, expectedly, I will say, and no pregnancy. And then before addressing this lady to the second IVF stimulation, well, she was treated with just LH, 150 units of recombinant LH for 2 months. And after 2 months, the AMH was 2.3. 1.3 was the basal value, 2.3 after the LH exposure. There was an increase into the number of antral follicles as well. And the ovarian stimulation protocol for the second cycle was the same as in the first one. And we got 8 mature oocytes, and we were able to create a blastocyst for this lady. Then we had a second case, a 31 years old woman. Again, she had secondary amenorrhea, LH almost undetectable. The MH was very, very low. And well, for this woman, we decided to treat her with extended LH administration before the first IVF. So 187 0.5 units of LH daily, 75 in the morning, and 112 in the evening. And well, after 35 days, the MH was 1.6. The patient was tired of the subcutaneous injection, so we prefer to move to the IVF, and again, maximal ovarian stimulation and 6M2 inseminated, and she was pregnant. So I think this may be in some way indicative, as I said, that, well, we can, in reality, gonadotrophins, well, may have some influence on the first phase of ovarian folliculogenesis, what was called in the past independent. So we are in this provocative article, we said that probably we have just one phase, which is the gonadotrophin dependent phase when talking about ovarian folliculogenesis. But of course, we recognize that the degree of dependency from gonadotrophins is very low at the beginning, while it increases throughout folliculogenesis. And so you may have women with a very similar number of primordial follicles, but with a different pool of antral follicles in relation to how much endogenous gonadotrophins are pushing onto the system. Do we have some independent evidence that this may be true? Well, we found this article very recently published, which is published by some colleagues from France. Didier Devoyer is one of the leading authors here. 12 women with hypothalamic amenorrhea who have been treated for 3 months with the pulsatile GnRH administration, the pump, the subcutaneous pump for the daily injection of GnRH agonist. And as you can see here, after 3 months of GnRH pulsatile GnRH agonist treatment, the AMH, well, from 1.69 moved to 2 nanogram ml, and this difference was statistically significant. We have two gonadotrophins. We talked about the LH. What about the FSH? Well, for FSH, things are, I think, much more difficult to be clinically demonstrated, simply because if you give LH to women, to regularly cycling women, they will continue having regular menstruation. On the other side, if you are giving high doses of FSH, well, this will promote follicular growth. So I see very difficult to run a study in which we give to women 60 days of recombinant FSH. But again, we now have some models that can give us some insights on what's going on. The duostim, for example. The duostim, in some way, in the duostim, our patients are exposed to 24 days at least in 1 month. 24 days they are exposed to recombinant FSH, to gonadotrophins, to FSH. And so let's see what happens when talking about folliculogenesis. We have published this article on human reproduction in which we reported, in which we, as many other authors already did it, we have showed a significant increase into the number of retrieved oocytes after the second stimulation cycle. When compared to the first one, we found a trend for 30% more oocytes in the second stimulation cycles when compared to the first one. And our main hypothesis, again, is a possible positive effect of a long exposure to high levels of FSH on pre-antral follicles. And if you are interested in this story, if you are interested in this new theory by our group and in this new possible way of stimulating the ovary, the prolonged ovarian stimulation, well, you can go through our recent articles. Now it's time for you. It's time for me to deliver to you take-home messages. Some in vitro evidence support a facilitating role of LH into the progression of follicles, the antral stage, which could indicate that in the absence of LH, there may be a reduction into the pool of antral follicles. Hypo is a good in vivo model for understanding the role of gonadotrophins depletion on ovarian function. Patients with long-lasting and deep suppression of gonadotrophin secretion may have very low AMH and antral follicle count. Even if limited to a few cases, the extended LH administration seems to be associated with an increase into the number of antral follicles. This protocol may permit to increase the number of retrieved oocytes, at least in hypo patients. We are now testing the hypothesis that all women with a relative LH deficiency, could be an LH below the median value, may benefit from the ELA protocol in terms of a possible increase into the number of recruitable follicles at the time of ovarian stimulation. And I thank you very much for your attention.